This week on the BackTable podcast.
The fact that you have to request a peer-to-peer for somebody that's about to lose their leg and somebody's not available and won't be back for 9 days and there's no backup. I mean, that is ridiculous. And unfortunately, they're removed enough from the direct patient contact that they can make a decision like that from across the phone lines in another part of the country, and then you have to go back to the patient and tell them this was denied. And they're very comfortable with that, unfortunately. But nothing new. It's just that now there, again, is a sense of urgency because it's been highlighted so much.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. First, a brief message from our sponsor. This discussion is supported by Philips OBL and ASC Solutions SymphonySuite, the industry leader in opening cardiovascular office-based labs and ambulatory surgery centers. With the convenience of a single trusted point of contact, they offer more of what you need to turn your passion into reality, including a full range of high-performing, highly specialized equipment and services, devices, financial options, site planning, guidance on construction partnerships, and more. When it comes to opening an OBL or ASC, SymphonySuite delivers convenience and support as the expert you need, the partner you trust. To learn more, visit philips.com/SymphonySuite. Now, back to the episode. We got a great episode today. It's something that we've seen a lot of chatter about, not only just talking to colleagues, but also on the OEIS forum. And so I'm really happy to have Bret Wiechmann join us. We're going to talk a little bit about the recent trend of insurance denials for necessary peripheral vascular interventions, which seem to many to be directly tied to the recent inflammatory New York Times article that was recently published that we're all aware of. I have with me co-host Krishna Mannava. Welcome back, Krishna.
Hey, Aaron. Thanks. Hi, Bret.
How are you? Thank you so much. Appreciate being on.
Yeah, and so Bret, the way we like to start these out is give just a little intro where you're at, what your practice looks like, and then for those who are unfamiliar, tell us a little bit about OEIS.
Well, thanks again for having me on, Aaron and Krishna. I am an interventional radiologist in private practice in Gainesville, Florida. The name of our practice is Vascular and Interventional Physicians. I've been in that practice for 26 years as of July. I'm one of the fortunate guys that has been in one practice my entire career, so very thankful for that. Pretty unusual, I think, to be in one practice your entire medical career. And we have 5 IRs. We recently brought on a new guy right out of fellowship and hope that he steps in and kind of jumps in and gets up to full speed very quickly. And so our practice is we cover a 520-bed private hospital. And we also have an office-based lab that we opened up in 2006. So we've been at this for about 17 years in the non-hospital side of service, as we tend to call it within OEIS. And we've been through a lot of riding the waves of reimbursement, riding the waves of political issues locally, riding the waves of turf battles and all that. So got a lot of experience from that standpoint.
Bret, real quick before we jump into OAS, the practice style you have is interesting because you have this hospitals plus the outpatient space. How often do you guys, how does it work in terms of rotation and coverage? Are you covering the OBL 2 days a week and the hospital 3 days a week? Can you tell us a little bit about that?
Right now, the way it is currently is I'm at the OBL probably 2 days a week and at the hospital 2.5 days a week. We have 5 IRs now, and so the mix of where I happen to be is a little bit different depending on the number of bodies we have and the number of spots that we have to fill. So when COVID hit, we closed on Fridays. I'm part of our radiology group, so we cover probably 5 or 6 different facilities in total between the diagnostic guys and the IR guys. The IR guys really only cover what we call VIP, which is the OBL, but we also cover the hospital. And so depending on the types of cases that an individual IR likes to do, they may have more or less time at the OBL. But it's kind of nice to have the best of both worlds. If there are cases that I think need to be done at the hospital, we do them at the hospital. If there are cases that we feel we can do in the office, then we do them in the office. But when COVID hit, we closed our OBL on Fridays because we were trying to save staff and allow them to keep their jobs. So we felt like if we closed on Fridays, then we closed a different facility on Thursdays, one of our other facilities on Wednesdays, so we could deal with the decreasing or shrinking volume and still have people keep their jobs, which we thought was pretty good. Now, of course, we're out of COVID, and it's really hard to put that toothpaste back in the tube and open back up on Fridays. So fortunately, we're still closed on Fridays, but right now it's about close to 50-50, I would say, between the OBL and the hospital for me.
Yeah, that's great. I mean, it sounds like you have a nice mix of both worlds, and that's probably why you've been there for 26 years, and it sounds like your partners have been there for a while too. Do you want to tell us a little bit about OEIS, how you got involved, and sort of where you are today, and then we'll dive into the topic for today?
Absolutely, and I appreciate the opportunity to tell you a little bit about the society, which we think has been very helpful for advocacy efforts and on a number of fronts. But in 2013, there were, I believe, either 12 or 15 of us that met in Dallas. And the idea behind it was to start a brand new medical society. None of us had ever done that before. Obviously, we had been members of our own kind of parent societies, if you will. But the goal of that meeting was to create, by design, a multi-specialty coalition of the willing, I guess, to advocate for the non-hospital side of service as a safe place to do procedures with less cost, while still maintaining financial and fiscal responsibility, promoting safety, dealing with setting up standards for things like peer review and appropriate use. And so the biggest part of that meeting in Dallas was figuring out what we're going to call ourselves, honestly. So the nice thing about it was we were able to get it all done in a weekend. And that was 10 years ago now. And even though we're still relatively young from a medical society standpoint, we feel like we've accomplished a lot. And we've created a peripheral vascular registry, which was a lot of heavy lifting by a number of people, particularly Jeff Carr, who's a cardiologist down in Texas. And we now have over 40,000 procedures in that peripheral module. We've formed multiple committees. We've started publishing, we're focusing on published research now again, and the initial safety data that we published was been out maybe a year or two. So we've proven that we can do these things safely in the office, and now we're just working on effectiveness data based on outcomes from people in the registry. So we have several different things that we're trying to accomplish through society, advocating for the space as a viable alternative for healthcare delivery, and also working with folks in DC with the Cardiovascular Coalition, key congressmen and senators that are our supporters. And we feel like we've gained a lot of ground, but we've got a lot of work to do still.
And it's a great conference for the audience. We've talked about it a bunch on this show because we've had many people who've spoken at OEIS on the show. Not just great talks, but just great networking all around. I think, Krishna, you could speak to that too. Just people in the space who can share, and everybody's very collaborative at this meeting. There's really no turf wars at the meeting, right? Everybody's open and a lot of honest discussions about successes and failures. So that's what I love about it.
We appreciate you being part of it too, Aaron. I know that you've been on faculty, and it's good to have a mix of people with various experiences, because what I do in Gainesville, Florida may not be what works or what looks like somebody's practice in Sacramento, California, or Boston, Massachusetts. So it's helpful to get a number of opinions with different arrangements.
Yeah, now you have these little regional meetings, right? Krishna, didn't you have one in the Midwest recently?
Yeah, I had a pleasure to attend the Mid-Atlantic OEIS chapter meeting. So it was great, actually. I mean, it was well attended, and so that's cool that the organization's growing to where you have chapters now.
Right. Very proud of our annual meeting. That is, we thought it would be almost impossible to do that in year one, but we were able to pull it off. And it's, other than the COVID years, it's grown very steadily, and our membership now is right about 1,000. So again, for a relatively young society, we think we're doing well, but still more things coming down the road, one of which is the topic we're going to talk about today.
Great segue to, the topic. Krishna, you want to dive into it?
Yeah, I can. And for those that don't know, I've had an OBL, an independent practice, for about 3.5 years myself, after being employed for 13 years prior to that. But my staff have come to me recently and brought some concerns to me as the owner of the business, saying, hey, we've met a lot of difficulties, and especially over the last couple months with a big thing, a pain point for us, which is prior authorization. And it was interesting, the timing of them, without any knowledge of articles out there, that they came to me and said, hey, look, a lot of things have changed in our processes and our interactions with payers. And prior auth has become a real problem for the staff. I don't know if you're noticing that in your practice, Bret.
Well, I'll start by saying pre-authorization has always been a bit of a challenge. Certainly nothing that is new about the painful process of getting pre-authorization, whether that's related to supervised exercise therapy. Have you checked all the boxes that a patient needs to have gone through, like a supervised exercise program or optimal medical therapy, documentation issues? All those things are part of what we have to do. But certainly I think with the most recent flurry of communication about atherectomy, whether it's through the New York Times or just a general opinion by some individuals from different specialties about the appropriate use of atherectomy, potential overuse, what's the clinical utility, I think that it's almost feeding this new wave of pre-authorization difficulties. That's just my opinion.
Yeah, because it's not just the New York Times article. There's the
ProPublica, right?
ProPublica, yeah, they've had a couple. I mean, there are clearly bad apples out there. It's just, I think the New York Times would be given, that's New York Times, and it was Sunday. It made it very public. It was front page. And what Krishna was saying to me, like we were talking about it, I don't know, even a few days after the article came out, Krishna was like, I'm afraid that insurance is going to start using this against us, right? And you kind of called it, right? Because then, like, now we're seeing people reporting this on the OEIS forum. So, Bret, maybe you can talk about what specifically people are reporting in terms of atherectomy denials.
Yeah, there have been probably 5 or 6 that I can recall off the top of my head that have had variations on the theme of new challenges with getting authorizations, from either a flat-out refusal to authorize atherectomy use prospectively at all through a couple of payers, to only approving atherectomy if a lesion is proved to be resistant to angioplasty, how you subject a patient to angioplasty, then you tell them, okay, well, this didn't work. Let's bring you back now for another procedure, and then we'll use atherectomy. You know, to me, it's almost a backwards way of thinking, but there are physicians on the OEIS Connect that have described previous patients with claudication that they've been managed effectively with or without intervention that develop a new ulcer, and the procedure may be approved for femoral popliteal codes, but not tibial codes. And that leads to the appeal process, or the peer-to-peer, which is just laughable, some of the responses that they get from these quote-unquote peers. I was telling Krishna earlier that I've had a pediatrician on as a peer-to-peer for approving certain procedures. I don't know a lot of peripheral vascular specialists that are treating pediatrics. It's a range of things from, again, flat-out refusal to only in certain situations, retrospectively, to not even approving a region of the leg that we would be intervening on most likely in a CLI patient, which is the tibial vessels. So very frustrating, and I'm not sure that we've seen the end of it.
Have you seen, timing-wise, this becoming more frustrating recently as opposed to the sort of baseline pain it always has been?
I do think it's added pain to an already painful process, yes, for sure. And whether that's all from, an inflammatory and sensational article, or just the criticism from certain specialists that are opposed to the utility of atherectomy in general, I suspect it's more of the public, as Aaron was saying, kind of the above-the-fold article in an international publication. I can't help but think that the timing isn't coincidental.
The question I had is, how do insurance companies, payers, or third-party prior authorization companies use a non-scientific article that potentially has a lot of bias built into it and change the way completely the healthcare is delivered? What's your thoughts on that, Bret?
I do think that that's unfortunate, and without getting too much off into the weeds here, that article was disappointing on a number of fronts, and I fear that this insurance denial thing is one of the unintended consequences, or who knows? I don't know the motivation of the authors here, but maybe it was an intended consequence. I can't say for sure, but I do think that it's unfortunate that the medical literature, and there's plenty of medical literature that supports the clinical utility of atherectomy in certain patients, is being downplayed and used as kind of almost a targeting against a very useful technology. And again, it missed the mark in so many ways because it didn't tell the benefits of atherectomy. It was just an inflammatory publication that just missed the mark.
My charge nurse, Diane, I'll use her name, she has sort of taken the lead as my quarterback for handling all of our interactions with prior auth and denials and so forth in our practice. And she put together a long list when I said, hey, Diane, tell me some specifics. And it's like a 3-page document she put together for me. So I just wanted to spend a few minutes touching base on some of these things. And I hope I'm not the only one out there experiencing some of this. But what we're noticing here in Columbus is that a lot of these large insurance companies are changing to use third parties for prior auth and pre-cert. So, for example, Humana now uses a company called Cohere. Aetna uses a company called Evacor. Anthem, and maybe others have another one, Carillon. So this is sort of newer to us, and we've noticed a trend this way with third parties. So we're dealing with third parties, not the payers. Yet the patients are dealing with payers, not these third parties, and it's becoming extremely difficult.
And I can't help but think that the insurance companies, the payers, don't enjoy the fact that there now is another barrier between our ability to make a decision about what we want to use or what kind of procedure a patient might need and themselves. So now we've got this third party that's kind of sandwiched in between. It's just one way, I think, that adds to their ability to not pay for appropriate procedures. And we've certainly seen some of that with these third parties that insert themselves. And I think I mentioned before that I'm part of a radiology group. We certainly have seen that historically on the imaging side, getting authorizations for MRIs or CT scans, usually higher end imaging. So it doesn't surprise me. It is one other concern that you've got a middleman now here involved in the whole decision-making process.
We also have some inconsistencies too that arise with these layers. Sometimes we'll have a request getting denied for one reason. We set up a peer-to-peer, and once we finally get that done, then we're hearing a completely different reasoning for the denial. So I don't know if you've seen that as well.
Yeah, it's kind of the whack-a-mole kind of game, right? You tell them this one day, and I say, well, we did include that documentation. It's right here in the report. Oh, well, then it's reason X or Y or Z why we're going to deny, and that's why I think it's just it's unfortunate. It's not very efficient. We spend so many hours with our billing and coding folks on any given day or any given week or any given month in running these things down. And at the end of the day, if you do not get authorization, all that falls to the patient. And so I don't know that in the inefficiencies that are part of any practice, whether it's an emergency that comes up or a procedure that takes 45 minutes longer than it should because you run into some technical difficulties, it's all the more reason that you have to make sure that all these things are under control, be able to control the things that ought to be very automated, really. And I just don't like the fact that there is potentially a pediatrician that's looking at a case review of mine and say, I don't think atherectomy is the appropriate procedure, or we're not going to authorize that.
Bret, can you tell us how that conversation went? Your rebuttal, how you address it? Because Mary Constantino had the same thing. She had a pediatrician. She also, I think, had a pulmonologist. And even when she gets somebody in vascular, it's like an old school, like a vascular who's retired, who's never done anything endovascular. So that was one of her questions for you. It's like, how do I address these peer-to-peers that aren't appropriate?
Yeah, that is a challenge, because I can tell you my conversation with the and nothing against pediatricians. I have good friends who are pediatricians. But when it comes to their value in this particular situation, I mean, it would be like me authorizing something related to a pediatrics practice. I don't know what that patient might need, but they get very evasive when you ask them to get a peer on your phone, because they think peer equals MD after their name or DO after their name. But they could be so out of touch with the realities of any particular medical case review that it really is absurd. So you have to, I mean, what I've come to do now is specifically ask what that physician's specialty is. And I won't have a peer-to-peer with somebody that at least doesn't have a general knowledge of what it is that we do. And I don't know how the companies feel about pushing back on that, but I can tell you that my personal conversation with the pediatrician, she was very evasive about telling me her specialty and wasn't even familiar with the anatomy. So you really can't expect them to have any meaningful understanding of what we're trying to do from a technical standpoint and why when we use particular devices.
Aaron, I'll share with you a story on peer-to-peer while we're on it. We very recently had a patient with CLI, necrotic wound. Non-invasive testing showed multi-level disease. We had to do a peer-to-peer to get it approved for an angio. The doc was unavailable to set up a peer-to-peer call because they were out of town or for whatever reason unavailable and they were returning in 9 days. So we were like, well, this patient needs revasc, and who's covering, or is there an alternate physician we can talk to? And they said, no, we don't have anyone, you have to wait. And that was it. Click.
And then the toes fall off in the meantime?
Or more. Some other things that we've noticed, and you talked about approving certain levels of disease. We're noticing that too. We're noticing things like, let's say for tibial work, we were previously able to get prior auth for the family of codes pertaining to all the tibial vessels. Now, recently we had a payer say, we will just approve 37228 or the angioplasty code, but not any of the other potential interventional codes for tibial work. So that's new to us too. And if any other type of intervention is performed, then we were given the green light to do a retro authorization with the possibility it would get approved retroactively.
Right, and that possibility probably being slim to none.
So doing just a straight angioplasty and hoping you don't have a dissection or needing to do anything further, that's just not the way we all practice.
No, it's not. It's not, and you have to wonder maybe in a subconscious way if you know that on the front end, and what if you run into a problem and you don't have the availability to put in a off-label coronary drug-eluting stent for a dissection that you get in a proximal anterior tibial or whatever. You know, those things, I think the detachment of payers from an actual patient on the table is just magnified by some of this stuff. I'd want to be able to have access to anything I have in my toolbox to get the best outcome for the patient that's on my table. And I don't know how anybody could state that is not appropriate or that is not covered. You hate to use the cliche argument of, well, what if it was your mom on the table, right? But I sometimes wonder whether or not they even think about it from that standpoint.
We're seeing some interesting stuff now that they need. Traditionally they wanted the percentage of stenosis, possibly maybe off of a non-invasive test. Now some are saying, well, we want a diagnostic angiogram. We want the length of the lesion, not just the degree of stenosis. We also want a certain degree of stenosis, and it has to be greater than 70 to 75% in addition to the length. So all these criteria are different with each payer.
Yeah, that's absurd. These payers are willing to subject a patient to a second procedure for an intervention rather than cover the things that we feel like we might, that there's a high likelihood that we will need, and have the patient come into your lab one time. I can't help but think that actually adds to their costs rather than saving them money. I mean, not to mention, I know this is probably foreign to some of these payers. I hate to sound overly cynical, but now you're putting that patient through another procedure, and I guarantee you they'll probably deny some of that. There's no guarantee that they will allow you to use, balloon or stent or whatever, no guarantee.
One of the things that I found disappointing with that article was I think it muddied claudication with CLI and blurred that a little bit. And I think that's carried over. We've noticed it carry over into payers. We'll have a patient with CLI and they'll be talking about a walking program. And I think they're just, anything they can use to make it difficult, they do.
Totally agree with that. I think they have, again, they're relatively detached. They don't have the knowledge base frequently, when you're having a peer-to-peer at least, to understand the difference between more advanced peripheral arterial disease like CLI patients. And, for them to say to a patient that's about to lose toes or a part of their foot, well, did you try a 12-week walking program? I mean, the silliness of that is not lost on any of us, but I can't believe that they aren't sitting in front of some computer that has a nice little flow chart with an algorithm that says, if the doctor says this, you say that. If they say that, then you say this. And this is probably something for artificial intelligence. I mean, I'm sure some of these payers would love to use that, and you're talking to a bot.
Another interesting, we can talk about this forever, but some other examples that drive us crazy now are, for example, I'm going to name Aetna, who is now using Evacor, and they just switched September 1st, so very recently, to using this third party. And they now consider IVUS for lower extremity PAD investigational, experimental, or unproven. And Aaron, we've had numerous episodes talking about the necessity, the need, the benefits of IVUS in our treatments. And now it's considered interventional by a very large payer, experimental. They do think IVUS is indicated and medically appropriate for iliac vein obstruction.
Well, there's really good data published within the last 6 months or so by Eric Sosemski on outcomes data related to use of IVUS for guiding lower extremity arterial interventions. I certainly think that there is value in using IVUS for venous intervention, but there's absolutely evidence to support its use in the arterial system, whether that's related to appropriate sizing or identifying dissections that you may miss angiographically. I mean, that has been shown. So I think that I'm hoping that with time and with these continued decisions of being experimental or unnecessary, that we put this well-done article, which is a large database, in front of them and say, no, it's not experimental. Look, your patients are going to do better if we use IVUS. And we all know on this call that it's critically important for the CLI patients for below-knee disease because we've historically undersized our balloons and stents and so on. So I think that it's time we get past that IVUS argument.
Does quoting data or articles like the Sosemski article, which I was going to mention, does that help on these peer-to-peer calls? This was a question that David Cohen was asking because he's looking for pro tips on hand. He's having the same frustrations you guys are having. He's looking for do I be firm and not so nice, or do I be super nice, but also, what direction do you take? Because if you come across cynical and angry, then chances are they're just going to deny, right?
Well, I'll say it this way. It's no silver bullet necessarily, but I think it's helpful. And you don't have to start the conversation being cynical, but I think it's going to be one of those read the room scenarios where who are you speaking to on a peer-to-peer? Do you think that they're getting the arguments? And are you familiar with this article that has shown the clinical utility of IVUS for lower extremity interventions or use of atherectomy? With atherectomy, there's some conflicting data, admittedly, but there's plenty of data that supports it. But I was telling Krishna earlier, we have conflicting evidence with aspirin. So, you're either a believer or you're sometimes you use it, 30 to 40% of the time, or you don't. And the use of it is one argument. The authorization for its use on a given patient is a different argument. I don't know how much a pediatrician or whoever your peer-to-peer reviewer is going to understand the depths of some of these meta-analysis that we have that shows their utility. They may not, it just may be way above their understanding. So I think I'd say it's helpful, and I'd have, a ready stash of published literature that supports your case. Is it going to make them change their mind and go, oh, well, Eric Sosemski said it, then I'm going to do it. I can't, I love Eric, but I don't know that he's got that much influence.
Yeah.
We have to now adjust the way we, our staff handles these prior auths, but this is creeping into the way we practice, from dictating whether we use IVUS or not to now we got recent guidance from an insurance company saying that staging of interventions is not indicated unless it's justified in the record. So valid reasons include any of the following, specifically quoted: patient instability, fluoroscopy use in excess of what's safe, a need to convert to general anesthesia, but we don't have those resources available, or if your contrast volume is greater than 250 mLs. So if we plan on doing any sort of staging of an intervention on a patient, we have to document and meet these criteria. So many of my patients have CKD. I don't want to use any amount of significant contrast. 250 would kill them, their kidneys. So now we're trying to think through all this stuff when we're in the middle of a complex CLI multi-level revasc, whether we, can stage them, whether we can bring them back. I mean, it's getting a little out of hand.
So if I understand you correctly, they're saying you can only stage if you've met those marks.
Yes.
Yet another payer may say, we want you to do a diagnostic study first, and then doesn't that seem like a total hypocrisy? They want to do staging under their definition, but not accept our definition of how we might stage a patient. I think this is just further evidence that there's this separation, there's this detachment of people that are calling the shots, and that's taking the ability of physicians to take care of the patients the way that we want to. And I know we spoke about this earlier. Maybe it's time for the voice of the patient to speak louder than the voice of the physicians.
Yeah, we have done that. I know we spoke about this, is we have talked to payers and we talked to patients and said, hey, look, your procedure is not being approved. We're meeting all these obstacles. We want to get you treated. We can get you in tomorrow, but you've got to advocate for yourself. We would behoove you to contact your insurance company, tell them your situation. And actually, surprisingly, we've had a handful of successes with this recently.
That's great. I do think that it may take more of that to really move the needle. It's very disappointing that it comes to that, because there's a distrust, I guess, or mistrust, whatever the right word is, that hangs over physicians as a result of these inflammatory articles, an unintended consequence, I would hope, for the authors in this kind of expose type publication. But I do think that the voice of the patient is critical. We have certainly not seemed to make it any easier for ourselves, despite trying to provide support from literature and the scientific reasons behind it. Maybe it needs to be on a more personal level.
Aaron, what are the other thought leaders out there? What are they experiencing?
We've got a number of questions from thought leaders, people that have been on this show before, like Srini Tumala, like I mentioned, Mary Constantino, Mike Watts, who I know is working with you, Bret, at OEIS on this task force. It's more, a lot of frustration. It's a lot, like Mary is very frustrated with these peer-to-peers, for example. She said that she's been having to pay for appeals. I don't know if you guys have experienced this, but there's this trend where you have to pay, and it's not a huge amount of money, but you have to pay like, I don't know, $50 to $100 for an appeal, and then they still deny you. And she's like, it's just all it does is kick the can down the road, and then they deny you again. And so that's one frustrating thing. This is a little bit more risque, but like she was saying, look, these insurance companies are essentially trying to practice medicine, and wouldn't there be a place for a class action lawsuit here? Because there's a lot of patients being affected when you put it all together. And I thought that was actually an interesting point. Bret, has that ever come up in your talks?
That specifically has not, although I hear rumblings of that, and it does sound like a great idea. The question is, how do you get a group together and push forward? Insurance companies carry a lot of clout, not just locally.
Expensive lawyers.
Yeah, exactly. And whether that's locally or at the state level or at the national level, and they don't want things to change. So again, it's part of the frustrating. It's a frustrating part of medicine right now that this is becoming more onerous in the era of paperless EMRs and all this. I think that it's harder and harder on the kind of behind the scenes of medicine. And I don't know, Krishna or Aaron, are you guys finding that you're having to spend more time for squeeze harder for less juice? That seems to be the case with us.
Absolutely. My team in my office are putting together this comprehensive sort of outline list spreadsheet of every single payer, every single new requirement that pops up. And we're kind of documenting now based on what will hit every single possible criteria for every payer for all of our clinical documentation, which is sometimes absurd.
And I think the documentation part is maybe the easier part, because even if you document, they can somehow find reason number 20, 21, 22 to deny a claim or to not give prior auth.
Yeah, that was one of David Cohen's questions with the peer-to-peer is, and I was given this advice back when I had the vein clinic, was if they deny you, you can kind of threaten them that you're going to put their name down in the medical record, especially if it's something like a wound, something that's going to lead to further, could be even malpractice and complication. And have you ever seen that work, or have you ever tried to do that with a peer-to-peer?
I've never done that myself. I've heard of people saying that as kind of a the stick to hit them with, but I don't know how effective that is. It sounds good in principle, and it might make you feel better, but I don't know that that's ever come to anything. It may be great if it would, because we would just document everything, right? We would document that like we would, Dr. X, the pediatrician, is not allowing me to use the device that I would like to use for you, Mrs. Jones, and I just don't know that I think it's a little bit of the paper tiger argument there, honestly.
Srini Tumla wanted to know if an insurance company doesn't pay or they're not covering the costs, like, is there an option to just not accept that insurance? I mean, can you just say, you know what, we don't take that insurance anymore? I know it's tricky because you want to take in as what patients you can, and you don't want to turn patients away, but have you had to make those decisions, either of you guys?
I have not. I mean, there are some plans that we're not part of, but it's not because of that specifically. And I do think that's a little bit of a slippery slope. If you tell a payer that might be 30% of your total patient population that, well, you denied this, we don't want to be part, they'll probably go, okay. And we'll go down to the next doctor down the road. Now, if you're in an area that you're the only provider, you may have a little bit more muscle there. But I think the option is there that, you say you're no longer going to participate in Blue Cross or Cigna or United, but you might be cutting off your nose to spite your face there.
Yeah.
Where do we go? I mean, from here, to segue into, what...
actionables.
Especially, Bret, with OEIS. What's your thoughts on how can we take all of this stuff that's happening around us and happening quickly, and how do we deal with this, or in a strategic way?
A really good question, and one that we are actively working on. This is all relatively brand new. We just started hearing about these reports within the last, I don't know, maybe 2 months at least. And so OEIS has put together a task force, which is going to consist of OEIS members from SCI, members from SIR, to basically it's kind of an ad hoc task force that we're going to try and sort this out. And I really think time is of the essence, because I don't think we've seen the worst of it yet. But I think one of the goals of the task force is to make some noise, because I think if we just let them continue to make this process more and more and more onerous, we are just validating them and just handing things over to them. We've got to fight back. How effective we can be, I think it really depends on how many people we can get on this task force to steer the boat in the right direction. I know we usually, when we're talking about OEIS and some of these conversations, we're talking about vascular interventionalists, IR, cardiology, vascular surgery, but maybe there's a role, as you and I have spoken about before, for some of these non-interventional specialties to be involved and kind of point out the problems that we're having, and because these are their patients that they're referring to us, and if we have our hands tied, how do we go back to them and say, I couldn't try everything I wanted to because we were denied?
That's a great point. I mean, when you talk about a voice and lobbying power, when it's just us as a relatively overall small field, when you throw in everyone that's involved with the care of our vascular patients, whether it's primary care, podiatry, nephrology, whoever it might be, wound care, and we join, and, I think it just amplifies potentially our voice.
No doubt. I think that that's imperative. I think it's a great idea. And identifying some of the key players, whether it's endocrinology or podiatry or family practice even. A lot of these patients will come from family physicians. They come and get their non-invasive studies for a gangrenous toe or two. They're trusting us to make the right decisions for the patient, for their patient that they send to us. And because we're physicians, we want to be able to treat them as effectively as we feel is appropriate. And if our hands are tied and an insurance company comes back and says, well, we don't want you to use that tool in your toolbox, then our options are to use what we think we need to and have them retrospectively authorize it, which again is a low yield, or that cost falls to the patient. And patients, these days, and the economy that we have, patients are very concerned about healthcare spending.
I think a joint societal effort is awesome. What do you think about, Bret and Aaron, also about industry's role as our partners in taking care of these patients and making these devices, not just atherectomy devices, but all the devices we use to treat patients? What do you think about their role in helping this fight?
I certainly think they've got skin in the game because they do manufacture these devices. They have studied these devices for years, clinical trials. They've gone through all the marketing efforts to sell the devices that they believe in. So they were kind of called out in this New York Times article as well. We all know the value of physician relationships with companies. These advances that are made, almost all these devices, the idea came from a physician, almost all of them that are out there. So the article did not mention the value of having those relationships. And quite honestly, if you've got an idea like that and it is a useful tool and there's a addressable market, why would you not be compensated for that? Steve Jobs got all the money that he was entitled to by coming up with a new platform for the computer. Why are physicians not allowed to do that? So I do think the device companies have some skin in the game here. And I do think that they have to be very careful of kind of avoiding the appearance of impropriety in some of these relationships and Sunshine Act and all that kind of stuff. So I think that they will kind of deal with this behind the scenes in a way that we would be more front and center. What do you think, Aaron?
They've got a lot of skin in the game. And like you said, they've already spent, billions of dollars in R&D to get these products on the market. And what are you going to just not advocate when insurance stops paying for it? And not to mention, they're letting all these patients down if they don't. So I guess the big question is kind of how do they work together, right? Especially if they're competitors, because there's a lot of different atherectomy devices out there. They should be putting their heads together as well and have a collective group to advocate and help, if not directly via their own resources, because we know they have expensive lawyers too, but at least support the societies that are pushing forward with this. So either directly or indirectly, I think that they should be. I don't know what they are doing. It'd be a good question. Maybe we could get somebody to represent them on the show.
Yeah, perfect case in point. Abbott just bought CSI for almost $900 million. You don't think that they're wanting to advocate for use of atherectomy and believe in that product? Absolutely they do. So they're certainly not going to just turn around right now because Cigna decides they don't like atherectomy and shelve a $900 million investment. And that's not going to happen.
Right. And maybe it's happening behind the scenes. We're not aware of it. I'm sure there's a lot of that going on, but it would be nice to have some transparency there so that we know, okay, there's some other people working or collaborate on it, do it together. So there's a combined force. Again, it goes to appearances. Like you were saying before, Brad, it's hard to align when, you have this article that makes it look like we're all just getting paid by device. It's a little bit tricky.
I think that would be a great idea to have somebody, a panel of folks from industry on the show and give us, what their thoughts are. What are your next 3 quarters of your fiscal year looking like, knowing that we're getting this pushback from payers, that we're getting this kind of negative attention, in an international above the fold article.
Yeah, and it's funny, Brent, you mentioned CSI, Brett, because I was wanting to get the CEO of CSI on the show to talk about the acquisition, and I forget who it was. It might have been, I don't know if it was you, Krishna, somebody suggested that, and then he was like, Aaron would love to come on the show. The whole acquisition kind of has to unfold, give me some time, and then will make it happen. So maybe he'd be willing to talk a bit about it. Like you said, that was his baby. And so I'm sure he's invested in it.
What do you guys think about long-term from a couple months ago going forward? If you had a crystal ball, what's your thoughts on amputation rates or limb loss rates in the future? Do you think there's going to be a significant impact on this going forward?
Well, I think that type of outcome data is going to be years down the road. And unfortunately, we've got to act now. But I do think that if you took a tool out of the toolbox that a lot of us believe is useful in many patients, then you're going to have some effect on your outcomes down the road. Unfortunately, it's going to be, if we wait for that, it's going to be too late.
That was another question from the audience. It was like, can you talk about the speed at which these efforts need to take place, right? I mean, I think it sounds pretty emergent at this point, but is there anything that we can do to like kind of speed it up? I mean, obviously you guys are trying to collect data, Bret, and I know that the forum's been a great place for people to present, their denials, and you're collecting all that data. Is there anything else that we can do to help you guys at OEIS kind of move things along?
Well, we always make the pitch for having some able-bodied workers to do some of the lifting, and no doubt about that. It's important that we have an equal representation from the specialties that are involved. It's important that we commit the time to this. I mean, this is a very important thing that we don't want to just either move too slowly on, just like when the proposed rule comes and we see that we're facing another 7% cut, we've got to mobilize the troops and we've got to have a plan of attack. And I agree with what both of you have said, that there's an urgency here that we've got to face, and we just can't let them drive the ship anymore in terms of specifically they being the payers, because again, we will find ourselves at some point just throwing up our hands and saying, okay, well, now what do we do? So I do think if there are people that are specifically interested in this, that they have connections with at a local or a regional level with their payers. If they play golf with them on the weekends, you got to get in front of the right people. And this goes all the way up to DC. I mean, let's face it, the insurance lobby is huge in DC, much more than OEIS influence or SIR or Sky or SVS. And I think those connections are going to be helpful in getting in front of the right people. But there is definitely a sense of urgency.
Taking it back to the patient, some of the language we provide our patients to fight themselves is they have two ways they can appeal a health plan decision. And one would be an internal appeal. And if their procedure or whatnot is denied or canceled, they have the right to internally request an appeal. And the insurance company is obligated to provide them a full and fair review, an explanation, and transparent decision. Especially if the case is urgent, they must expedite it also. And then also they have the right to request an external review as well, independent third-party review. So those are some things that we're sort of arming our patients with. I don't know how effective that is and how many of our patients are willing to go that mile.
Well, I think it's interesting that you've had some success with some of your patients within your practice that have seemed to have made a positive effect. And, if we get enough of those similar experiences and we can give them the talk track, if you will, to lean on the payers themselves directly out of the voice of directly out of the mouth of a patient, maybe a combination of our efforts and their efforts would be effective.
Right.
Well, it's about the hour, guys. I think we covered a lot. Any final thoughts before we finish up here, Bret?
I would just say that as frustrating as it can be in dealing with this, again, not something that is new. It's unfortunate that we're having to deal with the latest shot across the bow for dealing with very sick patients that unfortunately are going to be compromised, I think, if some of these decisions hold true and if we don't push back. The fact that you have to request a peer-to-peer for somebody that's about to lose their leg and somebody's not available and won't be back for 9 days and there's no backup. I mean, that is ridiculous. And unfortunately, they're removed enough from the direct patient contact that they can make a decision like that from across the phone lines in another part of the country, and then you have to go back to the patient and tell them this was denied. And they're very comfortable with that, unfortunately. But Nothing new. It's just that now there, again, is a sense of urgency because it's been highlighted so much.
Krishna, anything to finish up with?
No, I think this was such an important topic and very relevant to the current climate. So I think this is just a foundation for a lot that we can and should be doing. So Bret, thanks so much for your efforts and societal efforts on getting all this going.
Yeah, thank you so much, Bret. I love y'all's idea of having some representatives from industry, so we'll start working on that so the audience can stay tuned.
Great. Well, thank you for having me on, and hopefully it's going to be meaningful to the listeners.
For sure. All right, thanks, everybody. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritts, and co-hosts
Chris Beck,
Sabine Dong,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manveer Singh Sudley.
Administrative support provided by Jamila Kinnebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.